This is Anand Kumar. It's wonderful to have you all here. Today we have a exceptional speaker from Dublin, Ireland, Ignacio Martin Loekis. Martin, you can correct me if I mispronounce that. Martin is a physician and professor at Trinity College, works at St. James Hospital in Dublin. He's a world expert in the area of sepsis, and he has a great interest in infectious diseases and antimicrobials. He's going to speak to us today on novel antibiotics and their place in therapy in the intensive care unit. It's a talk that I'm really looking forward to. I hope you are too. Ignacio?
Thank you very much. Thank you very much, Anand. So I'm going to share my screen in a second. So again, thank you very much, Anand, for the introduction. So my name is Ignacio Martin Loekis. As Anand said, I am a Spanish doctor working in Dublin. And I'm going to talk in the next 40 to 45 minutes about novel antibiotics and their place in therapy in the intensive care unit. So first of all, these are my conflict of interest for the last year, industry and academic. So, and with no delay, I'm going to start that first, the total global antibiotic consumption is quite high, as we know. It has increased dramatically in the last 10, 20 years, from 50 to 70 billion standard units. You have here displayed the major consumers of antibiotics, being the United States as the first. And what means is that we have a trend in consumption of last resource antibiotics because, of course, resistance are in the rise. These are data from the European Union, 2016, showing that the number of antibiotics consumed by different countries has increased dramatically. And this is important because there are some countries that they were traditionally having a low consumption of antibiotics, and they are now showing in the last years a high consumption, pretty much because of the Carbapenem resistant bacteria, so that we will talk about in the following minutes. So it is also surprising, this is a classical slide about the innovation gap. So up to 2000, we didn't have any discoveries of new major classes of antibiotics. And you see that 3 classes of antibiotics were included, with the last one that has been peptidomimetic antibiotics target against the outer membrane, in this case against Pseudomonas aeruginosa, and we see that there is a big gap. So which are the priorities? Priorities are, they are classified in three parts. First is critical, high, and medium. And as you can see, the critical priority is showing that gram-negative agents are required for the treatment of very sick patients. This is something that has been agreed by the US and the European Union. And with this initiative, there was an objective that was coming from the IDSA of the 10 new drugs for by 2020. You see that all of these drugs that you have on the right-hand side have been approved. We have only one to get the agreement of 10 to 2020, so we got it this. So there are some practical issues in the antibiotic development, and I think that what is important is to have a good regulatory path for the development of new antibiotics. So that means that agencies as the FDA or the EMA, they need to put some help in this development. However, we are facing some financial constraints because a new antibiotic developed is going to have a net value of 50 million. However, there are some things that the companies are not going to be happy with, because antibiotics looks benefit with extensive use, so it's not a drug that is going to last forever. The guidelines promote short antibiotic use against other drugs that they are going to be chronic. So that means that when we compare with other type of drugs as chemotherapy, the mass cost of a drug is very limited compared to. So for that reason, in many occasions, the discovery of antibiotics is not really worth it. However, there are potential solutions. We need to look for new substance to screen. There are some partnerships between private and public agencies that they are going to help in order to get better drugs for resistant pathogens in order to get unmet needs. However, at the same time, we need to consider which way we are going to use when we are using antibiotics. And this is helping with the use of molecular diagnostics in order to develop short course of antibiotics to minimize overuse, with a public commitment and the most important part, that is prevention. So these are the potential US FDA approval of selected antibiotics. As you can see, we are going to discuss about these during the talk, but you see that in pink, you have many of these antibiotics that they are beta-lactams. Some others, they are using other molecules, but the vast majority of them, they are beta-lactams. So the unmet needs for antibiotics are going to be summarized in two. So first, broad and narrow spectrum drugs against difficult to treat resistant gram-negative bacteria. So I will discuss about difficult resistant bacteria term. So I think that is a quite interesting term in the classification, including those that produce carbapenemase, as we have only very certain number of agents that they are available. However, many of them, as you know, they are quite toxic. And the for gram-positives, that was not a high priority, a critical priority by the WHO, but still MRSA and Enterococcus showed a higher efficacy. So before we start with the antibiotics that we are going to discuss, I think that it's important to take into account which are the analysis populations that we have when we are talking about clinical studies. Safety, microbiological intent to treat, clinically evaluable, and microbiological evaluable. So all of these terms are going to be discussed during the lecture. So we are going to start with gram-positives. As you can see in this cartoon, the number of gram-positive agents is much limited than gram-negatives. So let's start with this. So these are the drugs that they have been coming, or they have been developed for Staph aureus. As you see, there are a good number of drugs. Many of them you are familiar with. Some of them, they have been already approved and they are being used in clinical practice. And I'm going to focus on these three, Ceftaroline, omadacycline, and Te-Desolate. So first, starting with Ceftaroline. Ceftaroline is a cephalosporin that has an effect against MRSA, but also has a very good effect against pen-resistant pneumococcal strains with other community-acquired bugs as Haemophilus influenza and Catarrhalis, and has effect against Enterobacteriaceae, but not ESBL. So it's difficult to select MRSA resistant, and this is one of the first studies showing that there is a binding affinity for penicillin binding proteins. So that is the mechanism of action. So, and as you can see in the slide, especially for strep pneumo, multi-resistant is showing a very good effect. So this is the trial that has been designed, Ceftaroline versus ceftriaxone. And I think that what is very important in this trial, I will show you the results immediately, but you see that the number of patients that they were very sick with PORT scores 3 or 4 was quite high, and also patients with renal impairment. So that mimics what happens in real life. And these are the results with the Focus 1 and Focus 2 study with the microbiological intention to treat analysis that there was some superiority with ceftaroline against ceftriaxone. So there are some subgroup analyses in this study. This is the study published by Song in Lancet Infectious Disease back in 2015. And you can see that the age group population and also the port score classes is quite relevant. And I think that this is important because it took this drug to be included in the current IDSA ATS guidelines. They were published in August 2019. And as you can see in the guidelines, intravenous cefuroxime was removed and ceftaroline was added. That was not approved before. So showing superior clinical outcomes compared to ceftriaxone in CAP because of strep pneumo and MSSA. So odomacycline is another drug. I'm not going to detail too much because this drug is probably for the treatment of community-acquired pneumonia that we don't see in the intensive care unit and was not inferior to moxifloxacin. As you can see, the patients were less sicker than in the FOCUS study, so I'm not going to stand too much in this particular drug. And another important feature when we talk about these drugs is, and especially with ceftaroline, is that we need some drugs that they are going to be used in pneumococcal infections, and especially strep pneumo community-acquired pneumonia. Because as you can see, this is a study that we published a couple of years ago with a group of Tony Torres. We see that there is a U-shape with the incidence and the mortality of patients with a strep pneumo. So despite of the recent advantages in drugs, we need new agents that they are going to give a better effect when we are facing this type of infections. So tedizolid is a novel OXA. So the indications are for skin and soft tissue infections and hospital and ventilator acquired pneumonia with the phase 3 finished studies. So the first message with this drug is that tedizolid has a very high concentration in the epithelial lining fluid that were even higher than free plasma concentrations. So that means that it is up to 20 or 40 times the amount of drug that you can get in plasma. So another important feature is that when we compare with the same family, that is linezolid, this is a modified molecule of linezolid, you see that the epithelial lining fluid penetration ratio is much, much higher. Knowing that linezolid has a good penetration in the lung, we see that tedizolid is going to represent a very high, a great alternative for penetration in the lung. So another important feature that is something that we face in critical care when we are using linezolid is the always scare problem of thrombopenia. As you can see in this slide, there is much less incidence of side effects of thrombopenia when we use tedizolid compared to the linezolid. So when we look at the study for ventilator-associated pneumonia, this is gram-positive infections, nosocomial pneumonia. This is the data that have been shown by Rich Wundering and colleagues. And you see that in the day 28 and the clinical cure, there was superior. However, tedizolid was considered not inferior to linezolid based on the investigator-assessed clinical response to the test of cure. So this is, again, a good alternative, and the comparison was quite tough because we are considering against linezolid that is a great anti-gram-positive agent. So probably in terms of summary with the MRSA infections, we can see that we have like three major areas: bacteremia, sepsis, endocarditis, where we have vancomycin and other additional drugs like daptomycin and ceftaroline; pneumonia and CNS infections, where we have discussed about the use of linezolid and tedizolid, but also ceftaroline and vancomycin with some problems with penetration; and soft tissue infections that we have, again, the presence of vancomycin, but we have other alternatives like ceftaroline, daptomycin, and of course the two OXAs, linezolid and tedizolid. So now we are going to move to the gram-negative agents. Gram-negative agents are really the high demand in current days. The network of emerging infections made a survey with a good high response, 500 people answer. And you see that in this score, MDR gram-negatives were going to be the unmet need of resistance in these current days. So as I introduced yourself before, there are different classifications about resistance. There is one that is called, that is the agreement between the ECDC and the CDC that was published by Maggirakos in CMI in 2012. That is the MDR, XDR, and PDR. However, I think that that is, in my opinion, more interesting, this classification, to consider patients that they are called difficult to treat resistant pathogens. So that means that they are resistant to first-line treatment. So this is a slide showing in a review the percentage of ICU stays in terms of bacteremia for gram-negative bacteria, and you see that when we are losing the ability to tackle the bacteria, we are going to increase, and you see that the ICU stay in bacteremia can go up to 80% when we have these difficult to treat resistant pathogens. So that means that they are resistant to first-line agents, pretty much carbapenems, other beta-lactams, or even fluoroquinolones. I think that a good example of these, there are different gram-negative agents, but I think that probably Pseudomonas aeruginosa is a paradigm of difficult to treat pathogen, and we will discuss about this shortly. So for this reason, so we have like a grading of disease from in Enterobacteriaceae from ESBL to carbapenem resistant bacteria. So we are going to talk a lot about ventilator-associated pneumonia and hospital-acquired pneumonia, because as you can see, when we take into account days under mechanical ventilation, you see that those patients that they develop VAP and they are mechanically ventilated, they are going to have 3 times longer time of stay, higher mortality, hospital stay, and hospital mortality rate. So these are the agents that I'm going to discuss. I'm going to talk more about those that they have been with higher developments. So this is the summary, and I think that before starting to the summary, we are going to classify multi-drug resistant pathogens based on the carbapenemase resistance, and we are going to have 3 major groups. So type A, that I think that the major exponent could be KPCs with Enterobacteriaceae and Pseudomonas. That these are the penicillinase. So group B, that they are the metalloenzymes, and here you have the IMI, the BIM, and the NNDM. So, and the last one is the oxacillins. The oxas are the representation where you have the Enterobacteriaceae, again, Pseudomonas, and Acinetobacter baumannii. So in other words, when we try to represent these 3 major classes of carbapenemases, you see that they are all going to be resistant to different antibiotics, but I think that probably the ones that they are giving us more headache are those that they are the metalloenzymes, because as you can see, they are resistant to all the antibiotics that they are at the moment in clinical practice. So we start with Ceftazidime avibactam. Ceftazidime avibactam is active against ESBL, also has activity against AMPCs and some CPEs, especially group A and group D, OXA48 and Pseudomonas. So it has some gaps, especially Acinetobacter, Stenotrophomonas, and Pseudomonas that they have some resistant mechanisms that we are going to discuss, and of course MRSA and anaerobes. So there is a very good surrogate of the lung penetration with the plasma levels. So that means that there is a very linear acquisition of the drug in the lung. And this is the study that was published by Tony Torres in Lancet Infectious Diseases in 2018. And you see that was comparable to the study drug Ceftazidime avibactam versus meropenem with similar results. So the key patients and disease characteristics is that these patients were sick. We see that 80% up to 90% of them, they have an Apache score from 10 to 20. They were not all of them ventilated. They had ventilated approximately 40% of the patients, and many of them, they require some prior antibiotic treatment. So these are the major studies I discussed about the reproof, that is the study with hospital-acquired pneumonia and BAP, but also this drug has been tested in complicated abdominal infections, urinary tract infections, and the last one that is quite interesting because we will talk about best available therapy with pathogen directed in ceftazidime resistant pathogens. So in real life, how does ceftazidime avibactam work? And this is a study from Pittsburgh showing that there is a clinical success of 60%. However, there is recurrence in 2 out of 10 patients, so that is not a small number, with some microbiological failure. So, and ceftazidime avibactam resistance was detected in 1/3 of the patients. So that means that in some Carbapenem resistant Enterobacteriaceae, probably there would be implementation of PKPD, or even to consider the use of combo therapy with either an aminoglucoside or another beta-lactam. So when we look at Klebsiella pneumonia bacteremia, you see that there are different combinations, and here you have the use of Carbapenem aminoglucosides, Carbapenem or colistin or others, and you see that the use of ceftazidime avibactam was showing a benefit, a clinical success rate of 85%. So against colistin, that is one of the last resources that we have in clinic for patients with Carbapenem resistant Enterobacteriaceae. This is another report in 2017 showing that the all-cause mortality at 30 days with ceftazidime avibactam was much lower than with the use of colistin. We have to take into account that there is toxicity with colistin. So colistin is, in general terms, not a good drug, and ceftazidime avibactam showed 65% probability of better outcomes. So the next drug that is having some characteristics with ceftolozane tazobactam, ceftazidime avibactam is ceftolozane tazobactam. Ceftolozane tazobactam is bactericidal, is again a modification of a beta-lactam. And I think that probably we have to make a summary that is a great anti-pseudomonal drug. However, it does not have activity against Carbapenemases as it happened before with ceftazidime as KPC or MBLs. So this is the aspect study that I had the opportunity to take part on it, comparing ceftolozane tazobactam versus meropenem with several primary endpoints, the FDA and the EMA at day 28 and at the test of cure in the clinical cure. And these are the results. Well, the first, before starting with the results, I think that it's important to say that in this study, all the patients were mechanically ventilated. This is the first study where all the patients were mechanically ventilated. Also, another interesting feature is that it was discovered that up to 20% of the patients, they had a very high creatinine clearance. So that means this has major implications for the treatment. And also in the terms of baseline pathogens, we have seen with different studies like the EPIC-2 study that Pseudomonas was the most prevalent pathogen, but we see that nowadays ESBL are getting more frequent in current clinical practice. So this is the clinical cure at the test of cure. This is the FDA primary endpoint. And you see, I haven't highlighted anything because it's showing that is equivalent meropenem versus Ceftolozane and tazobactam. When we look at the microbiological eradication of the test of cure, there is a benefit in the drug with Pseudomonas aeruginosa. So there is more killing effect and more micro eradication when we look at Ceftolozane and tazobactam versus meropenem. And another important feature that is always the risk of ESBL, as we discussed before, so has a very good activity against ESBL, including Klebsiella pneumonia. So another important feature from this study, from the aspect study, is that when we look at the population, we see that treatment failure was showing benefit with the use of Ceftolozane and tazobactam, and also patients that they had hospital-acquired pneumonia that they needed to be mechanically ventilated. This is an important feature. And this is an important feature because we know when we look at the population that is having pneumonia in the hospital, from patients not ventilated in the ICU with HAP, ventilated and ventilated with HAP, you see that there is a grading of mortality showing the highest patients that they have ventilated hospital-acquired pneumonia because probably, as I said before, treatment failure. And I would like to bring this concept because when we look at different studies, I talk about the reprove, I talk about the aspect, and I will talk about imipenem relabactam later on, and I'm not going to talk about telavancin, but these are the studies that have been published. You see that patients that they have ventilator hospital-acquired pneumonia showing highest mortality, showing much higher mortality than BAP. And another important feature is that when we compare one drug against the other in patients with ventilated hospital-acquired pneumonia, you see that there is still relevance. So probably we need to consider at times, is this the same disease or we are talking about a different disease? So for this reason, we wrote this review paper. It's a task force about the update in treatment of nosocomial infection in a kind of lights, traffic lights. And you can see that when we are moving from the ward to the ICU, the ones that they are showing the highest mortality are those that they are developing HAP on the ward and those that they are developing HAP in ICU and they have treatment failure and they need to be mechanically ventilated. What about Pseudomonas? Because we discussed a little bit about Pseudomonas. I think that we have to consider three major mechanisms. The first is beta-lactamases. The second is the efflux pumps. And here I represent the four major efflux pumps and also the outer membrane. So looking at the different drugs that we have available, Ceftolozane is showing the best spectrum against these three mechanisms, efflux pumps, in this case, XY and AB, beta-lactamase enzyme, especially the AMC, and the outer membrane with the porous loss that we will discuss later on with other drugs. So what happens when we are looking at strains of Pseudomonas aeruginosa in ICU pneumonia in patients that they have non-susceptible, they are not susceptible to beta-lactams? Here you have three groups: piperacillin tazobactam resistant, meropenem resistant, and Ceftazidime resistant. So this is more like we have in real life, and you see that the probability of coverage of Pseudomonas in this is up to 70% of the cases. So we are talking about a very good anti-pseudomonal agent. When we look at the different, and this is data from last year in SMITTE, and we look at the spectrum and the activity in a very wide collection of samples, you see with beta-lactams compared to beta-lactams, again, there is a very good susceptibility that is 15% higher than other drugs that we are currently using in daily clinical practice. So I think that probably it's time to compare these two new drugs. I think that they are different drugs, that they have different spectrum. Ceftazidime avibactam has activity against ESBL and activity against Carbapenemase A and D, as I said before, with OXA 48. whether ceftolozane tazobactam has no effect against the KPCs, but has a very stable against Pseudomonal, especially with resistant mechanisms with the porins, the outer membrane, flux pumps, and the beta-lactamase, and is active against ESBL, as we have seen with the Subgroup study. So another drug is imipenem relabactam. Imipenem relabactam is a modification of imipenem. It's showing a good activity against AMC, or producing Pseudomonas aeruginosa. However, does not have effect against class B. This is a current problem with many drugs, that they are not effective against metalloenzymes and not active against class D, especially OXA48. So that limits a little bit the spectrum. And another important feature is that it's not against Acinetobacter baumannii, as it happens again with some of the drugs that we have discussed. So this is the study called RESTORE, that it was imipenem relabactam versus piperacillin tazobactam, including a very big number of patients, 537 patients. And you see that the use of imipenem relabactam was especially positive in those patients that they have a high Apache score. And as I said before, when we look at ventilated HAP, so patients that they had a hospital-acquired pneumonia and they required to be ventilated, you see that there is a great effect that is similar to ventilator-associated pneumonia, and no difference in patients with HAP that they were not ventilated. Meropenem barbobactam is a very interesting drug as well. It's a novel boronic acid-based beta-lactams inhibitor. So has optimized inhibition for Carbapenemase, a KPC, and is a good option for Carbapenem-resistant Enterobacteriaceae. It has a good penetration, and the dose has a proportional increase with the Cmax and the area under the curve with the dose, as you can see in this slide. There are two major studies. One is the Tango 1, that is for urinary tract infection and pyelonephritis, and the Tango 2, that is the best available therapy that I introduced before. That is a kind of a different design, and you see that you have included many different infections, including UTIs, intra-abdominal, HAP and BAP, and bacteremia. So the Tango 1, that is the urinary tract infection, you see that is a straightforward design, showing that in these patients, as expected, the majority of the microorganisms were E. coli, followed by Klebsiella pneumonia. And you see that there is, in the clinical cure, a superiority with meropenem barbobactam in terms of the microbiological intention to treat population. And the Tango 2, I think that is very, very interesting, because, as I said before, is taking into account different serious infections, not related to pneumonia or pyelonephritis or intra-abdominal. So it's about anything, and taking into best available therapy. So that means that is against whatever we are giving in clinical practice. So it's quite realistic study, and it was interrupted by the DSMB, as it was showed that it had a higher superiority. So again, the number of patients is a pity that was stopped, because the number of patients is very limited. I think that it's going to be difficult to make good estimations about the results, because you see that it was included only 47 patients. However, interestingly, they had a good number of patients immunosuppressed, up to 40%, with a limited number of patients in ICU. These are the numbers. The majority were bacteremia, and the majority were receiving meropenem, especially the bacteria resistant were Klebsiella pneumonia, resistant to carbapenems. And this is the efficacy endpoints. You see that there was efficacy at the end of treatment in the overall success, clinical cure, and microbiological cure. But as I said before, we have a little bit of a dilemma, because the number of patients was very limited, but very interesting result, showing a very successful rate. So when we look at the subgroups, we see that in the subgroups, again, we have to consider that the number of patients was limited, but I think that is interesting to see that it was superior in all the ages, and also there was a benefit in patients that they were immunocompromised, that, as we know, that is a big thing in daily clinical practice, because these patients, they have resistant bacteria. In many occasions, treatment failure is a norm. So cefiderocol is another cephalosporin. It's called a Trojan horse mechanism. It's a very interesting effect. It's a siderophore cephalosporin that is using the siderophone ion transport system in order to increase the stability to the granulate the beta-lactams, and is using a passive transport in the porins with the use of siderophore ferric iron transport, as you can see in the slide, in this area, in this slide. So cefiderocol is highly active against many strains, and here we see that is sensitive against two bacteria that they were commented before, Stenotrophomonas and Acinetobacter. So this is the summary of cefiderocol. Is active against CR strains with the name Apex, so Acinetobacter and Steno, as I said to you, with Pseudomonas, Escherichia coli, and Klebsiella. And as I said before, one of the problems with many of the drugs and many of the beta-lactams is the resistance against carbapenemase type B metalloenzymes, and you see that in this agent is sensitive. So this is a good news. So in vitro activity against CRE, you see that is quite impressive here. In vitro activity against Pseudomonas as well, and in vitro activity against Acinetobacter baumannii. That is something that we haven't seen too much with other drugs. So this is the study that was done in urinary tract infection. As you can see, published in Lancet in 2018, you see that the primary endpoint and the secondary endpoints, they were superior with the use of cefiderocol in urinary tract infection. But when we look at pneumonia, this is the study from Rich Wundering, there is no benefit, no differences when we are looking at the clinical cure 14 or 28 days respectively. So another interesting aspect in this study is that in this study, cefiderocol was against meropenem with a quite high dose. As you know, the recommendation of meropenem is 1 gram every 8 hours, but in this study, the dose of meropenem was quite high, 2 grams every 8 hours. So, and this is the last study with cefiderocol that is called the Credible study. So it's not published, it's just you can access at the FDA documents with some preliminary data. Again, the design of best available therapy, and you see that the clinical cure rates were approximately 50%. We are waiting for the results that we will have it then probably shortly. So 2 drugs that I'm going to talk briefly, eravacycline, that is a cyclin similar to tigacycline, is bacteriostatic and no activity against Pseudomonas, as it doesn't have tigacycline, with a good activity against CRE class A, B, and D, with some dose adjustment in renal and liver failure. Plasomycin, again, another very powerful antibiotic. This is an aminoglycoside showing a good effect against multi-resistant bacteria, including CRE as KPC, but no with metalloenzymes, NDM. Well, it does have a limited activity, it's not totally ineffective, and especially with Acinetobacter. So this is a study, again, a little bit limited with the number of patients published in the New England as a letter last year, and showing plasomycin a better outcome compared to colistin in patients with either HAP or BAP. And interestingly enough, when we compare not only the efficacy, but also the toxicity, you see that there is less toxic than colistin, of course. Other drugs, this is morepavadin, that is a very interesting drug because it does have an outer membrane protein targeting protein. So the effect is, as we can see, pretty much monoclonal. So it is against Pseudomonas aeruginosa. and again is very sensitive against MDR and XDR isolates altogether. And when we look and we compare against meropenem, you see that there is in vitro time kill is very powerful. That is an effect that disappears, and we need to increase the doses of meropenem substantially. And when we talk about risk factors, and I'm going to finish with these, I think that it's important to consider the American guidelines. This is the risk factors for multi-drug resistant pathogens, organ failure, or in the European guidelines, when we have the presence of septic shock and the presence of epidemiology. These are the difference of the guidelines in between American and European guidelines. And I think that I wanted to emphasize that epidemiology is all, so we cannot recommend one antibiotic or another. This is the reason that this is showing that if you are in a country, or interestingly enough, if you are in the same ICU, sorry, in the same hospital, but in a different ICU, the prevalence of one bacteria or another is going to be substantially different. So this is the reason that you need to adjust against your local epidemiology. So the difficult to treat, as we said, we have different compounds for this. So making recommendations, first line treatment for ESBL. I think that before answering this question, we have to go back to the Merino trial that was published last year. So that was a very pragmatic study in bloodstream infection, trying to randomize patients with piperacillin tazobactam versus meropenem, as you know, with the efficacy of meropenem. And for this reason, we can eliminate for ESBL, especially when the piperacillin tazobactam MIC is low, the use of piperacillin. So alternatives for when the MIC is higher, we have carbapenems and the two cephalosporins that I mentioned before, ceftolozane tazobactam and ceftazidime avibactam, with some other second-line agents, as I mentioned before, cefiderocol, meropenem barbobactam, and imipenem relabactam. So when we look at Pseudomonas aeruginosa, happy days, we have many alternatives at the moment. We only had in the past some issues with some agents, but I think that now, especially with the development of ceftolozane tazobactam and the mechanisms of resistance and cefiderocol, we have a backbone for treatment. So, and this is the role for the new carbapenem resistant strains. So carbapenem resistant Enterobacteriaceae, probably the first would be in an order Ceftazidime avibactam. This is a personal opinion, followed by meropenem barbobactam, imipenem relabactam, and finally cefiderocol. Carbapenem resistant Pseudomonas, as I said before, probably ceftolozane tazobactam and cefiderocol, and probably murepabedin. However, the study is on hold. And for carbapenem resistant Acinetobacter, that is still with limitations, cefiderocol represents an alternative with eravacycline, and of course, plasmomycin that might be sensitive but is limited effect. So this is the new antibiotics, as you can see in this slide. We have some alternatives, especially for the very well threat of the metalloenzymes. As you see with the metalloenzymes, you see that there is some antibiotics that they are showing effect. And when we look at the treatment in terms of empirical treatment, I think that to reinforce that we are suspecting Pseudomonas or we are suspecting KPCs, I think that we have to go for either ceftolozane tazobactam or we have to go for ceftazidime avibactam. And when we are looking for target therapy, we look at the slide. So that is summarized that Pseudomonas, ceftolozane tazobactam, in case that we have KPCs or OXA48, ceftazidime avibactam. As I said before, for metalloenzymes, we don't have many alternatives. Probably the use of combination of ceftazidime avibactam with atrione and colistin and cefiderocol. For Acinetobacter, we don't have many alternatives, probably cefiderocol and another etiologies, so consider this. So, and I'm going to finish with a very broad message. I think that it is important to consider that inappropriate antibiotic treatment is associated to a higher mortality. So this is a meta-analysis of 57 studies showing that when you are not giving the right antibiotic, the mortality is going to increase. This is a paper from my chair, Anand Kumar, showing that in terms of hypotension, not giving right antibiotics is going to affect dramatically the survival. But also in this study that we published this year is showing that the use of antibiotics is not only restricted to patients with cardiovascular failure. As we can see, patients that they are developing more cardiovascular failure, they are going to have less effect with inappropriate antibiotic therapy. And I'm keeping this open for discussion. So should we need to give the antibiotics early when the patient is not that sick? So these are the conclusions. So great news, we have new agents. There is superiority in terms of some regions for CRE. Many of the antibiotics are modifications. However, there are some resistant mechanisms that they are interesting, that they are above the beta-lactamase, as we said, the pouring and the efflux pumps. However, the high cost might limit in poor resource settings. And I think that, again, individual institution and local problems mandate the prescription of antibiotics. And thank you very much for your time today.
All right. Can you all hear me? Ignacio, can you hear me?
Yeah, sure.
Okay, good. I assume everybody else can as well then. Ignacio, while we wait for questions to come in, which I'll read as we get them, I wanted to ask you a couple of things myself. One of the findings that you mentioned that I found particularly intriguing is that ceftaroline appears to be superior to ceftriaxone for CAP, in particular as it relates to strep pneumo and to MSSA. And
yeah,
I'm wondering what you think the reason for that is, in that as far as strep pneumo goes, for organisms that don't have high level pen resistance, the time above MIC is basically 100% with ceftriaxone. For MSSA, it's significantly more limited in terms of the time above MIC. So
correct.
is your sense that the superiority of ceftriaxone for strep pneumo is dominantly because we've been getting more and more of these high level pen resistant strains that are just resistant to ceftriaxone?
Well, I think that this is a great comment and difficult answer, but I think that probably is what you mentioned. I think that we are giving more and more beta-lactams, and probably the benefit, as I showed with the study with Ceftaroline, was related to the pen-resistant strep pneumo. So another important feature, and this is something that it is not related to the microorganism, it is related to also the type of patient. In many of the trials that when we are doing in community acquired pneumonia, we are excluding very sick patients. So I think that in the Ceftaroline trials, we were including more patients that they were sicker than we have seen before. We have seen many studies, as I showed before, with gram-negative agents that they are BAP or HIP with treatment failure. But in CAP, I am missing more studies that they are really against ICU patients. So the answer is probably the spectrum. I think that in pen resistant, we cannot say that we have to suggest the use of Ceftaroline in every setting. I think that in settings that they have pen resistant, especially in those settings where Ceftaroline might be a benefit. And the other thing is that, and this, I think that this is the reason that the American guidelines brought these, suggesting that there is superiority probably in these pen-resistant settings.
And for MSSA, on the other hand, the time of MIC for ceftriaxone is pretty modest. I think it's around 30%, if I recall. Uh, and I
Correct.
assume that the reason you might get superiority with Ceftaroline is that you have a greater time of MIC. So on the one hand, you have um, improvement because of greater potency or activity of Ceftaroline for MSSA, and on the other hand, for strep pneumo, you're covering more organisms of the strep,
Correct.
of the resistant strep pneumo. So I presume that's what's going on. Is that your take as well?
That is my take as well. And also, because you would think about MRSA a lot, but we have seen that the number of MRSA pneumonia, at least in Europe, has declined dramatically. And in some other places in the world, that has also declined. So I think that to have a good agent against pen resistant and MSSA is good news. I agree.
Okay. Let me. I'm told that we don't have any questions from the audience yet, so let me encourage the audience to throw in some questions. But in the meantime, I have lots of questions, so what the heck? Um, the other thing that I found that you said that was very interesting, and I just wanted to get your thoughts, is the increased mortality risk of hospital-acquired hospital-acquired ventilator pneumonia as opposed to straight-up ventilator pneumonia. Now, we saw something similar to that in our septic shock database, where we found basically that if you had gotten antibiotics before you developed hypotension, you actually had a much worse outcome than if you got hypotension, came in with septic shock, and then got your
Mhm.
antibiotics. And I think what it is a selection bias, basically. In the one hand, you have received antibiotics and you failed them because you progressed. Um, so I wonder if that might not be the same thing with hospital acquired ventilator pneumonia, where presumably they got antibiotics on the ward, failed those antibiotics, and then went on to be ventilated, as opposed to those who get ventilation right off and then get treated. Do you think that might be what's causing that?
Yeah, I agree. And this is the reason that I mentioned in this slide one of the review papers that we published a few weeks ago, showing these traffic lights about the mortality associated to these patients. So let me explain to you where this come from. So when we were analyzing the aspect study, Ceftolozane tazobactam against meropenem, we saw that there was same efficacy with the use of ceftolozane tazobactam against meropenem. So, but that was very, very surprising is that patients with hospital-acquired pneumonia that they require to be ventilated, they have a much higher mortality. So, and that made us to start to consider what you say. I think that there is a bias. Definitely is a bias because these kind of patients, they might show more treatment failure and they have for sure received, and this is something that it is again in the paper. So patients that they were having HAP, they had more antibiotics before. So there is for sure somehow treatment failure. So
Yeah, and so
I
so,
think that,
so those people who got antibiotics, who had HAP, who got
yeah,
antibiotics and got better,
yeah,
they never get ventilated, so they're
they
out,
never get
basically.
ventilated. Yeah, we cannot say that patients that they have we my message is not we have to start to be scared of a patient that has a HAP on the ward. Like, no, I'm only saying that these patients that they are coming to the ICU after a HAP that is not doing well, I think that we have to
Yes.
consider that these guys have a very high risk, even higher than patients with BAP. So just to consider it when we are treating our patients. So, and maybe to hit very hard with these guys with new agents, because many of them, they have acquired resistance in many occasions.
Right. We still don't have any other questions, so I get to ask more questions, and this is great because when we go to meetings, Ignacio, we often are so busy with things that we don't get to just kind of talk kind of thing. So this is great. Um, I found it myself not that difficult by and large to choose antibiotics when I know the pathogen I'm dealing with. But I think where it gets very difficult is when you are in an environment of uncertainty, basically when you're giving empiric therapy. And so you
Correct.
touched a little bit on how you might go about choosing antibiotics for VAP or hospital-acquired ventilator pneumonia. Um, but I wonder if you can elaborate on that. Like, what's your approach to say, okay, here's a patient who's, say, relatively healthy and comes in, um, uh, maybe a young patient with trauma, and then ends up being intubated for pulmonary injury. So his baseline, he's pretty healthy. So how would you empirically consider treating him as opposed to somebody, for example, who's got um, malignancy and COPD and gets pneumonia or gets into COPD, respiratory failure, ends up ventilated, and then gets pneumonia? How do you approach these things differently?
Okay, so I mentioned it a little bit, probably a little bit fast for limited time, but I think to me the most important is to consider the risk factors of resistant acquisition, and I think that looking at the two major guidelines at the moment are the American guidelines and the European guidelines. The major guidelines, they are reporting the well-known risk factors. So if the patient has received antibiotics previously, if the patient has been admitted to a hospital, so all of these patients that you were referring, Anand, so patients that they are with malignancies, so they have been all receiving antibiotics. So resistance is a norm, but I think that these are easy. These are easy. So the problem is those, and it happens from time to time, that they are with young patients that they develop a Pseudomonas aeruginosa as an early BAP onset. And this is the difficult one. And I think that in the European guidelines, we try to tackle that with an approach that was based on two factors. One was the presence of septic shock. If the patient has a worse outcome, so in terms of severity. And the second is epidemiology. And I mentioned the epidemiology, and that is the reason that in a lecture like this, you cannot recommend, oh, let's give antibiotic A or let's give antibiotic B, because I think that it totally depends on the place that you are working. For instance, I had the opportunity to work in two different countries. I worked in Spain, where the resistance were quite high in some occasions. And in these particular patients, I saw patients that they were developing multi-drug resistant pathogens in early onset VAP episodes. And this is something that we published back in 2016, so that we published a paper about the risk factors in patients with early onset that they had multi-resistant organisms. And we found two major factors. As I said before, the presence of septic shock, and the second is when the prevalence of multi-drug resistant pathogens in your unit is above 25%. So the 25% is an arbitrary number, and so we cannot say that 25 or 35, so we need to use a threshold. But if you are in a place with high resistance, this is the reason that you might have episodes of early onset with multi-drug resistant pathogens, severity and ecology.
Okay, thank you very much, Ignacio. I just want to mention, while we have a little bit of time, that I want to thank Merck for sponsoring this event and for the contribution of the Critical Care Forum as well. The one thing I want to mention, and this may be in the last minute or two, I don't know exactly how much time we have, so if we get cut off, I apologize. But one of the most interesting things I'm finding with the evolution of how to approach uh, severe infections empirically, in the past, we've basically looked at, what are the likely organisms, and we've gone at it in that approach. But what I see as an emerging approach in order to try to limit the extensive use of antibiotics now is that we're factoring in how sick the patient is. So, for example, if you have septic shock, um, then we're saying that you really can't afford to miss the organism right off the bat, and so you tend to go very expansively in terms of your antibiotics. But I think what we're seeing is an emerging consensus that if you have severe sepsis, um, that you have more time, and so you can, and you have more room to be wrong, so that you can delay your initiation of empiric antibiotics. You can do some initial investigations, and also you can probably start with a somewhat narrower group of antibiotics or antibiotic alone than you might in somebody who was more ill and more at risk of immediate death if you get it wrong. So that's one of the things I think that's emerging as an approach that I think people should be aware of. We are
Yeah,
a few minutes. Sorry, go ahead.
no, I agree with you. And I mentioned, as the last, the last slides about a manuscript that we just published this year, how, sometimes I agree with you. I think that when the patient is very sick, there is no room for a mistake. You have no other options. You have to hit hard. And when the patient is not that sick, you might have an option. But in our study, it was an observational study with all the limitations that you can understand. But what we discover is that when the patient is getting sicker, the possibilities that the appropriate antibiotic therapy is making the effect is less. So that means that when the patient is developing more and more organ failure, we are getting into a problem that probably the antibiotic is having more residual effects compared to supportive treatment. So I think that, nowadays that we are living in the days of antibiotic stewardship, I truly defend antibiotic stewardship, don't get me wrong, but I think that when we have a sick patient, we don't need to wait until the patient is in septic shock to give the right antibiotic. So I think that we need to consider, to be savvy to treat the patient when we have room.
Absolutely. Well, Ignacio, thank you for your time. We're a little bit over. Been a pleasure seeing you again, and I'll probably give you a shout for some other activities that we might be able to do together. Okay, I want to say goodbye to everybody, and again, thank Merck and the Canadian Critical Care Forum for their support for this event.
Thank you very much.
Have a good day. Ignacio, I'll see you another time.
Thank you very much, Anand.